talking about positive pressure adjuncts. And then we'll talk a little bit about muscle training, both inspiratory and expiratory. And then get into the internal and the external vibration devices, which are there to mobilize secretions. And why are you, get the spinning thing here? Why aren't you working with me instead of against me? There we go. So, some of the objectives talking about the different devices. Now I'm going to cover a lot of the devices. I will point out to you which ones I want you to focus on, because some of them are just there for completeness. Why are we hanging up? I don't know. Try this again. As far as the high-frequency chest wall oscillation, I'll hold off on a demo until another day, but I do encourage you to try it on and see what your impression of it is, because it's a very effective tool. Maybe I won't do any lecturing, I don't know.
Eat it.
Yeah, you do. We've tested on it, and so you tell me.
Why is it not stuck in? God.
Okay, we'll just do it this way. You can still read it. So some stuff as far as readings out of Egan. Also some stuff out of Butler. And there is no performance evaluations related to this stuff. So we got a breath of relief. But let's see a quick video. All right. So, idea between a lot of these devices is twofold. One is to mobilize secretions, to push them towards the more central airway so that they'll be able to be coughed out easier, with the intent of the fact that those secretions that are being retained are probably causing atelectasis and causing hypoxemia secondary to that. Lots of different devices that we have. First one I want to just mention is the continuous positive airway pressure, CPAP devices. Lori hasn't talked about sleep, has she? Sleep obstruction?
Yeah.
Okay, so you have a little bit of background on that. But there's bunches of different devices that we end up having. We'll focus on just a generic CPAP unit. The second portion of positive pressure is what we're going to call PEP therapy, positive expiratory pressure, where we're actually creating some sort of a resistance on exhalation to try and pop those airways that are obstructed back open again. So what do you need to provide CPAP? Well, we always have to have a gas source that's going to generate a high enough flow so that positive pressure is maintained. I need some sort of a circuit that the patient breathes through. Could be used attached to a mask, could be attached to an endotracheal or tracheostomy tube. And on the opposite end of that, there's going to be some sort of a threshold resistor, some sort of a device that's going to create the positive pressure that is giving us a consistent level of CPAP. And obviously going to be some sort of interface to attach to the patient. Oops, wrong one. So here's your typical home unit where we would use nasal CPAP for patients with obstructive sleep apnea. Some of them, because it's dry gas at high flows, you may want to humidify it. So if the patient is complaining of dryness, there's an option that we have as far as the CPAP humidifier. This, I think, is a slide that you saw in the 1210, or you may be seeing. I don't know where she's at in 1210 yet, but basically what I have is my gas flow on the far left side. That gas flow is flowing through a humidifier to some sort of a reservoir, which then has an interface to the patient where I'm monitoring the pressure, and this mechanism is how I create that expiratory pressure. Okay, so it looks really similar to our high flow nasal cannula system. The difference being is that there's something on the expiratory limb. Okay, so where that was just a single limb going to the patient, now I have something where as the patient exhales, they're exhaling against a resistor. Another example, instead of using a series of flow meters, I'm using a downs flow generator with an analyzer, just like we were using on the OptiFlow. So that high flow can go to the mask. Here's a different type of resistor. This one happens to be a spring-loaded valve, but basically the patient is exhaling and a constant positive pressure is being maintained. That's the issue. We've talked about the downs flow generator prior. That's the one we're making the adjustment for the high flow setup. So whatever you're using to get that gas flow, that's what's going to generate the high enough flow to maintain the pressure in a constant state. The circuit itself, again, we talked about having a pressure manometer and a humidifier, an oxygen analyzer, and you also need some sort of a pressure relief. The interface, again, can either be a face mask, as you've seen, a nasal mask, directly to the ET tube or to the tracheostomy, and the expiratory resistor is the thing that is maintaining that pressure at a constant level. And again, just going back to Module B, I don't even know what was Module B, whatever. Spontaneous breath creating a negative intrathoracic pressure. On inspiration, positive pressure. On expiration, all we're doing is taking that and raising the baseline. So instead of that transition, small negative, small positive being at 0, that now is at some higher level, 5, 10, whatever we desired for our level of CPAP. The idea being is that I want to re-recruit those collapsed alveoli. There's something I can do to pop those alveoli back open again. In doing so, hopefully we reduce the work of breathing. We improve the distribution of ventilation, so areas that were not being properly ventilated, now those alveoli can be opened up. And possibly mobilize secretions also. If I'm getting the alveoli open, that must mean that I have the ability then to push any secretions that we're trapping down there out. I'm not going to worry about the lab on this. So let me talk about questions on CPAP. Yeah.
So if we're bringing the baseline up, then wouldn't it make our negative a positive, and therefore...
It's still negative relative to the baseline. Whatever pressure you're putting that patient on when you elevate them, any negative pressure, yes, it's still positive, I understand it, but it's negative relative to that upper baseline.
But then when we breathe out, wouldn't that make it that we have to overcome that positive pressure now to breathe out? So
Yeah.
why, like, wouldn't there be a number that we could accidentally come upon that then you couldn't overcome that pressure, and therefore...
Well, you're saying could I have a positive pressure so high that it impedes ventilation? Yeah. Yes.
Would that number be, like, doesn't seem to be like a
It
very
would be
large...
very excessive.
Oh, would it?
Yes.
Yeah.
Yeah. Do this. Take a breath in. Exhale halfway. Now take a breath from there. That is damn uncomfortable, isn't it? The reason being is that you have a normal FRC. They don't. That's why the application of PEEP or CPAP is beneficial for them, because it brings them back to the normal baseline that they're going to be breathing at. Okay. Certainly over the summer, but I don't think we do it in here at all. But one of the things that Lori will have available and Amber will have available is a mouthpiece and a filter, so you can put yourself on CPAP and feel the odd feeling that is there. But again, it's odd simply because our FRC is normal. Theirs isn't. So let me move on then to the second positive pressure adjunct, which is the use of what we're going to call PEP therapy. Not PEEP, PEP, positive expiratory pressure. Two different classifications. There's a fixed orifice style device, and there's one that's got a threshold resistor, and we'll talk about each of them in turn. Again, with CPAP, I'm doing that small positive and negative pressure at an elevated baseline. Here, I'm bringing that positive pressure only on expiration. So I breathe in normally at normal atmospheric pressure, but when I'm exhaling, I'm creating a positive pressure inside the airways. Got the distinction? Okay. Goal being that equal pressure point pushing it further peripherally. So the airways aren't collapsing. I'm keeping the airways open. I'm splinting them, if you will. If I keep them open, that means that any trapped gas beyond that now can exhale, and along with that, secretion removal. This is the first type of a device. It's called the Resistex. You don't need to know brand names, but you need to know concepts. What I'm doing is, as I'm here's the patient on the left-hand side of that mouthpiece. They're drawing in air, and then as they are exhaling, there's a one-way valves, a series of one-way valves. They're only allowed to exhale through this cap, and the cap has different size orifices. Doesn't sound right, but okay. Different size orifices that add a different level of resistance. Nice part about it is you can use it in conjunction with a regular breathing treatment. Just splice it in line. I inhale from my nebulizer, but when I'm exhaling through this resistance. Another type of device is called the TheraPep. Works on the same exact principle. Take a breath in at atmospheric pressure, but when I'm exhaling through a variable sized orifice, a variable sized hole. And that hole is going to generate a certain amount of back pressure that's going to splint those airways open. Alternatively, there's also one called a threshold device. This one's a little bit different. What it has is a spring in there that acts as a resistor. So as I'm exhaling against a plate that is based on the spring tension is generating some pressure. All three of them do the same thing. They create a positive pressure on exhalation, splinting the airway open, hopefully getting more air out, and along with that, more secretions out. The nice part about the threshold resistor is it's not affected by flow. The other two can be. So the amount of pressure that they generate is variable depending upon the patient's expiratory flow rate. With a spring-loaded one, it's not. So that's the big difference between them. And yeah, we can go ahead and attach it to a mask if the patient can have. Okay. We do this intermittently on spontaneously breathing patients. There's no pressurized gas required. There's just those series of one-way valves. So the inspiration is drawn from one part, and the expiration is through the fixed orifice or through the threshold resistor. And that positive pressure is on exhalation. Keep doing that. So again, just as far as how the technique is done, going to go through our normal assessment and positioning of the patient. That should be in a comfortable position, sitting upright. We're going to adjust the device so that it's at the lowest amount of resistance, the largest opening, and then have them breathe out through their, breathe in, take a breath in and breathe out through the device. The normal breath, we're not talking about a total lung capacity, but a good, nice sized deep breath in, holding it, and an exhale with moderate force through that device. And they're going to feel some resistance to gas flow, and that's the whole idea. I can then measure the amount of pressure that I'm generating, and I want to go ahead and reduce the orifice size until I get about a 10 to 20. So PEP therapy, the targeted pressure you're looking for is 10 to 20 centimeters of water. 10 to 20 centimeters of water. Did I mention 10 to 20? We have them do this for 10 to 20 breaths, and then we have them do what is called a huff cough, also known as a forced expiratory technique. We'll talk more about those next time. But and what it basically is, it's a cough without closing the glottis. Have the patient take a breath in, and then do a forceful exhalation, i.e. huff, and the sounding of it. So what they're able to do is just move those secretions forward after doing the 10 to 20 breaths at 10 to 20 centimeters of water pressure. Again, lots of goals. The idea being is that we're mobilizing secretions. We're reducing atelectasis, mobilizing secretions that are causing the atelectasis, and in the process then improving blood gases and x-rays and all the other stuff. Where would we use it? In air trapping. We talked about mobilization of secretions, reverse atelectasis, and again, why not, if I'm doing bronchodilator therapy, optimize that bronchodilator therapy by having the patient's airway being maintained open. No absolute contraindications, relative contraindications. Patient can't follow directions. Patient has hemodynamic instability. Something with maybe a oral or facial skull surgery or trauma. They have nosebleeds. They're nauseous. Kind of common sense stuff. And of course, untreated pneumothorax. While we're not treating that pneumothorax and all these therapies, I'm not entirely sure. Recognize that you are causing some positive pressure, so that may lead to problems with intracranial pressure, may have some problems with cardiovascular, not allowing blood flow to return. Sometimes they have some air swallowing, which can lead to nausea and vomiting. If you're using a mask, you can get skin breakdown and claustrophobia. And in theory, pulmonary barotrauma, although that's an extremely rare complication. Again, your normal monitoring that you're going to do for them, as far as just normal vital signs and their response to the therapy. Questions on PEP. Positive expiratory pressure designed to mobilize secretions and keep airways open. If I keep that airway patent and don't allow it to collapse, it's going to have better airflow and secretion clearance. Let's take a look at the other end of the spectrum. How about an inspiratory muscle training? This is where we're focusing on the inspiratory phase. And again, we have the same kind of idea. A fixed orifice and a threshold resistor. In fact, in some cases, they're exactly the same device. We're just using it in a different technique. Again, this is something that we associate with a pulmonary rehab program where we're over a long time period trying to get them to strengthen their respiratory muscles. So this is something we probably will never see in an acute care hospital, something which you might see in the rehab or if you're in home care. The idea being is that with PEP therapy, remember, we took a breath in, and then when we exhaled, we had a resistor. On this one, it's set up so that as you take a breath in, you're breathing in through a resistor. So that fixed orifice or the threshold resistor is on the inspiratory side of the equation. Here's an example of one of them, and it basically has variable size orifices, variable size openings, that as they draw breath in, they're drawing in through there, and they're just exhaling out in a passive fashion. Another device that has different colors that are showing different size openings, as you can see. Again, the same process. This one has an adjustable collar that allows for changing the airway resistance. And of course, we had the same threshold resistance we had for PEP therapy we can use as an inspiratory muscle trainer. So what we want to do is we want to measure their maximal inspiratory pressure. Okay? Did we do that last semester? Correct. MEP and MIP? Yeah. So if I know what their maximal inspiratory pressure is, I want to use a percentage of it, and we'll get to the percentage in a second, but I'm going to set that inspiratory resistor to the largest opening to start with, and then monitoring their pressure as they take the breath in. And the goal here is to achieve 30% of their MIP. 30% of whatever their resting maximal inspiratory pressure is, I want to get about a third of that. We're going to seal their lips tightly, and we're going to monitor them as the amount of pressure that they can generate. And they're going to go ahead and do that for about 15 minutes, couple times a day. And again, next time you come in for the pulmonary rehab, we see how they're doing in that setting, and we increase the resistance as time goes on. The liver is evil and must be punished. How fitting it's in a bar, right? All right, let's talk about internal and external vibration devices. Lots of internal ones that we have, and I'll talk about the ones that I want you to focus on that you may see clinically. Some of these are so bizarre, I have never seen them, but they're here. But how about a video?
You know, it's also probably shocking right now to try to think of that amount of money and say, this is what I'm going to do. But what are some of your immediate plans? What do you definitely know you want to do with some of this money?
Well,
just saying. First one I want you to know, and this is one that you should be aware of because it is used a lot, is called the flutter device. Okay? What it is a steel ball, stainless steel ball, that is in a circular cone. And the mouthpiece on the left-hand side, as the patient takes, they breathe in, taking normal inspiration, but as they exhale, they're exhaling through that, pushing that ball. But the ball is not a constant force, it causes a vibration as they're exhaling through it. Very simple method to generate some positive expiratory pressure that is oscillating, that is not a constant pressure. 2 phases, loosen and mobilize the secretions, and then having the patient cough to get rid of it entirely. So I slowly inhale, maybe a little bit deeper, but don't fill your lungs completely. Hold the breath, put the flutter into the mouth. By changing the tilt of it, I change the amount of resistance that ball is going to create. Exhale through it at a reasonably fast but not a forceful speed. Exhale to more than normal but not completely emptying. And the attempt here is to suppress a cough so we can do a huff cough after repeating this for a few breaths. So here we have the patient sitting. You can see them holding the flutter device, but as we tip it, we change the amount of that force that gravity is creating on that ball. Stage 2, the mucus elimination component. Again, we have them take a deep breath. We exhale forcefully through the flutter, and then we're going to end up doing a forced expiratory technique, or huff cough, again in the same process. So I mobilize secretions, try to get them towards the central airway, and then use the device to forcefully exhale through it and create up, and then do a series of huff coughs. That's the flutter. Steel ball. Gravity. Second one is called an acapella. Acapella. Again, creating pep, but the positive expiratory pressure is variable. It oscillates. It changes. Same two components. The nice part about the acapella is it's not gravity dependent. The position of it doesn't matter. Rather, what we're doing is adjusting a dial in the back that's going to allow us to have a differing amount of resistance that we're exhaling against. And there's a YouTube, I'm not going to waste time going through, but it's, go ahead and watch it. Same idea, same exact things. Want to go ahead and have them do not a complete inhalation, but a deep inhalation, and then reasonably fast, but not forceful. Same process. And then the mucus elimination component is exactly the same. Forcefully exhale, and then do a couple of huff coughs. You can disassemble this and clean it. Don't need to know the specifics, but point being is that these can be taken apart and cleaned. Now these I'm just doing for explanation because they're just so bizarre. I've never seen these. First one is called the lung flute. It just sounds wrong. The only product that uses sound vibration to create. And again, the idea being is that it mobilizes the secretions so they're easier to cough up. It looks like this. It looks like a flute. Or probably more a cornet or something, or a clarinet, I should say. Strange. And again, what they should end up doing is just doing a couple of breaths and resting. And they do 20 sets of these 2 breaths. And they cough, and if you really are excited, you can go look it up. It's the lung flute. A second one is a cornet. Again, I've never seen this, but it looks like it's kind of an interesting idea. It's basically just a collapsible rubber tube that is inside a larger tube, and as you exhale, there's a variable resistance created as you exhale through that tube.
Like a kazoo.
It's like a kazoo. There you go. And she looks just so excited to be doing her cornet therapy. And you can adjust the settings to adjust the amount of resistance that you have, and you can even take it with an aerosol medication. God knows why. Another one is called the Quake. Another one is called the Aerobica. Whatever. Okay, there's all kind of different devices trying to create a variable PEP. That's the key word. The 2 I want you to know are the acapella and the flutter. All right. Another idea. Let's not worry about this external stuff. Let's go ahead and actually apply some vibrational therapy directly to the airways. The first one I want you to recognize is the intermittent percussive ventilation. Again, it's designed for the same exact thing, mobilize secretions, reduce atelectasis. We're using here a higher driving gas pressure. It's going to produce internal chest vibrations that are quite rapid, and it's in a pulsation technique, so that we're having a prolonged inspiration and also then a prolonged exhalation to exhale the air medication back out, and we can use medication along with it. Let me play a quick little video for you that kind of explains what the device looks like. Mount Clemens does this, right? Oh, we have one too, I know, but I mean they use it there. So if you go to McLaren Macomb, you'll end up seeing this clinically used.
Hey everybody, it's Scott Krigo. We're going to go over how to do an IPV treatment on a mechanically ventilated patient. Alright, so we've got the IPV machine, we've got a 50 psi source on our oxygen tank, but we would typically be using an O2 source from the wall. Alright, and then all of our material over here for our circuit is right here disassembled. Okay, and I'm going to show you how to put all this stuff back together. Okay, now, first thing, here's your nebulizer cup. Just fits in here and then it locks in place. Alright, so it's got a good snug fit to it. Alright, now this is kind of green and so is that, so those two match up. Alright, and if you really think about it, there's nowhere else for it to go, which is nice. Alright, spring for the phasotron goes in here, and see when we apply pressure to it, that's going to bounce up and down and give you the Venturi effect. Okay, here's the cap of the phasotron. Alright, now extra accessories, just a regular bacteria filter. Alright, so we'll have some moisture that kind of comes up here, right, and this can just kind of keep that from kind of splattering everywhere. Alright, recommended change out is when this gets pretty saturated because it can increase resistance levels a little bit. Alright, now we have this put together. Remember with your nebulizer, okay, that there's a little diffuser piece in there. I don't know if we can see that. Sometimes that's loose or missing. Alright, if it's loose or missing, it won't nebulize without that piece, so make sure that's in there. Alright, and then here is our circuit. And if you notice, it's color-coded as well, which is a wonderful thing. We've got this little arrow on this piece here on this filter. That always goes towards the patient. Alright, usually on the red line there'll be a small filter as well. Alright, and we would like to put that in, usually close to the patient as we can, but somewhere along that accessory line would be ideal. Now, to get it set up, it's color-coded. So we go white to white. White's your power line. Alright, yellow is flow for your nebulizer. Okay, remember, arrow goes to the patient. Alright, your green line is your remote switch if you're going to be having the patient control it. With our ventilated patient, that's most likely not going to happen. Alright, but to connect it, it would be right here. Okay, and finally, we have our accessory line. We can put that right up there. Okay, now, other end goes over to the machine. Color code that as well. We've got red, white, green, and yellow. Alright, and those
Pretty
are
much
the same.
same.
That drives our nebulizer. This drives the phasotron or powers the unit. This is your accessory gauge, okay, your manometer, and this would be your remote line here. Alright, so when this is activated, if I just hit that button, it interrupts flow and will stop the machine there, okay, so. But since we're not going to use it, we'll just disconnect that and it'll just be in continuous cycle. Alright, as far as the machine is concerned, here's our operational pressure, or our drive pressure. Right, this is considered your mean airway pressure. Alright, what I want to do is set that according to the compliance of the lung. So a more compliant lung, I'll set it lower, so in the 25 to 35 range. Alright, a stiffer set of lungs, I'm going to set that higher. Alright, we're going to need more pressure to move that chest around, so I would set it 35 to 45. Okay, this is again for an adult patient. Alright, your percussion level, how much we manipulate that mean airway pressure. Okay, so we've got an easy setting, alright, which makes the mean airway pressure go a little more faster, less fluctuations in mean airway pressure. Alright, harder setting, alright, which makes the mean airway pressure fluctuate more. Okay, when I typically set it at, there's an arrow up here, and I just set that at high noon. Okay, I'll start there, and then as I start on my treatment, every minute or so, I'll just change my frequency level. Okay, both sides of that, because one section may work well with one certain section of the lung. All right, another frequency may work at another section of the lung. All right, we don't know which one's going to work where. All right, so we're just going to try and blanketly cover all of them. All right, and this is simply the on and off switch of the unit, though. Okay, now what I'm going to also do is I'm going to connect a closed suction system. All right to here. All right, and then this would directly go to my ET tube or trach tube. All right, what I want to do is suction out the patient's throat, get any of those glottic secretions out of the way, all right, because I want to deflate the cuff. When I deflate the cuff, I increase the avenue for mobilization, though, right? Because one of the main indications for this IPV treatment is if we can't mobilize secretions properly, though, okay? The other good indication is it is a nice recruitment tool for the lung, too, all right? So any condition that gives you any of those two items would be a good use, all right? And then we'll disconnect it to our test pump, all right?
Using atelectasis.
So what we've got to do is connect it to the 50 psi source. Normally that would be on the wall, but in this case, we'll go right to the oxygen tank. Never directly to the flow meter because it doesn't have enough flow to power the unit. All right, so I'll attach my test lung. All right, and then we'll get it started. Okay, see where my drive pressure is, about 35, so kind of middle of the road there. All right, started at the noon position. Okay, and you can see what it would be doing to the lung. You want to observe the chest, good movement. Okay. Don't have good movement, make sure the machine's set up properly, or you may need to go up on the pressure a little bit. Now, as the treatment goes, all right, I'm just going to move the frequency around a little bit. And notice it changes the pitch and moves the mean airway pressure around. Okay? All right. Typically, our treatments will last 15 minutes. Okay, so make sure you put enough solution in here of whatever you're nebulizing. All right, for at least 15 minutes, all right, and it usually goes through and nebulizes 1 mil per minute, all right. Now, when we're done with the treatment, all right, we're going to have to obviously suction the patient out, and if there's any secretions that come up through the breathing tube at that point, we can suction them out with our closed suction system, or if most of the secretions will come up through the oropharynx, we'll just suction out the back of their throat, all right. Then we'll reinflate the cuff, check a good cuff pressure, put them back on the ventilator and do a full ventilator check, all right. Now, clean up on this machine, we would disassemble it the same way I would do it, rinse it with sterile water, all right, and then I would put it in a patient sterile bag there, okay? When the bag gets nasty, you just get a new bag. Okay? And that's our IPV treatment.
Get the gist? So that's intermittent positive pressure ventilation, also known as a percussion air. And we do have one of these in the lab, so what we'll do is get them both set up so you can at least, if you want to try them, feel what your patient experience is. It's pretty freaky. Usually it lasts 2 minutes. Again, there's only those two settings, driving pressure, which is tied to the mean airway pressure. For right now, don't worry so much about that, but it's basically what pressure are we going to be oscillating around, and then the degree to which we're causing these oscillations. Is it just a slow oscillation or is it rapid? So we go ahead and plug it in, as the video showed, turn it on, adjust the working pressure to wherever you want it to be done. 25 is a good spot. Put the frequency dial to 12 o'clock as he showed. Put on a test lung and begin vibration. We can adjust that adjust the pressure and adjust the oscillation, as he was mentioning, to change the frequency that's being applied, which possibly can mobilize different portions of the lungs at different times. A second one, which we have up here in the front, and we'll get that hooked up also, is called the MetaNeb. This is an older model. There's a newer model out that's basically the same thing, but it's got a new faceplate on it. Enhances mucus clearance again. Again, it takes care of atelectasis because of that. It has really 3 different therapies built into it. It has an aerosol delivery that if all you want to do is just do a breathing treatment, some bronchodilators or some mucolytics, it'll do that. It's a damn expensive flow meter, but that's what it is. It'll also then cause you could flip it over to lung expansion, which basically is going to do CPAP. It's going to have an elevation in airway pressure. Let the patient breathe there, and then flip it over to secretion clearance, and it has the vibratory effect also. And it has a specialized circuit, and Amber and I can go through that with you and do a demo on it. And then on the bottom side is a master switch, and where we hook it up to our 50 psi gas source.
So we have to nebulize something with these, though?
You normally do, yeah. It's part of, instead of just doing a simple aerosol therapy, I'm doing an aerosol along with these other two components with it. Oop. You see their young child doing it. Apply it to a face mask if the patient can't keep the mouthpiece in. So continuous positive expiratory pressure. We're allowing the pressure to keep the airways open and splint them, and then we're doing the high frequency oscillation, pneumatically changing the pressure to cause that vibratory effect. So the same two processes. And again, this same kind of a setup that you would end up using. We initially were going to have to set it to CPAP, and then where we get some resistance to airflow, and then have the patient breathe in and out. And we're basically doing a couple minutes with the increase in pressure, and then a couple of minutes of vibration, and having the patient cough. Okay. So those are the two primary ones you'll end up seeing of a direct application of vibrations to the airway. Let's talk about a different one, and this is the high frequency chest wall compression. Let me see how long this video is. I don't want to bore you with it because it's pretty straightforward as far as how it operates. And Hill-Rom is one of the manufacturers. And they're there. Don't worry about that. It's called the vest, and it basically is a device that causes an oscillatory pressure applied to the external portions of the chest wall, causing vibrations, secretion mobilization, relief of atelectasis. Same story. And you can see there's different size vests that you end up having. Some of them are reusable, some of them are disposable. Here's what the controls are, and what you're really setting on this is the frequency and the depth and the duration. So how long do you want it? So it's an inflatable vest that is connected with hoses to this, basically a pulse generator. The vest inflates and deflates very rapidly, applying gentle pressure to the chest wall, with the idea being is that it's going to shake the lungs to loosen any secretions that are adhering to the walls of the airways and mobilizing them along. Very small volumes are being applied at a variable flow rate, changing the frequency. Usually the lower frequencies move larger volumes, where the higher frequencies generate higher flows. There you can see where the tubing from the device attaches to the vest itself, and there's various Velcro adjustments that you can make to the vest itself. So here you can see the patient sitting, and the nice part about this is the patients can apply it themselves. Where chest PT, someone else has to beat your chest. Here the cystic fibrosis patient can just sit and do therapy by themselves. Making adjustments. There's a foot control that then allows them to go ahead and turn it on, turn it off. Usually we want to start at a pressure about 5 to 6, a frequency of 10 to 15. And you can do therapy while you have the vest on. And in 5 to 10 minutes, stop and do a cough mechanism. Just another example of a not a complete vest, but just a chest vest, and how it attaches. And again, the same idea. We started with the foot control after connecting it. A little bit lower pressures than the full vest. Frequency is about the same, and you can see the goals here. If I haven't said this before, positive pressure to open up the alveoli, or splint open the airways, and vibration to cause those secretions to be mobilized towards a more central airway. Indications whenever you have patients who have difficulty secretion clearance, cystic fibrosis, bronchiectasis, and they have presence of atelectasis secondary to them, mucus plugging. We talked about some of the other diseases there. Absolute contraindications. patients who have injuries or hemorrhaging or hemodynamic instability, again, in the home that wouldn't be an issue. Relative contraindications, you can see they're pretty much obvious. Some hazards that can occur, although they're very rare. And there's this stupid thing that's an Egan. And it's the last day on my job. Okay. Questions?